Welcome to Triage Cancer's webinar, Options When Losing Health Insurance at Work. I'd like to introduce you to our speaker for today. Amanda is a staff attorney at Triage Cancer. Prior to joining our organization, she spent more than a decade counseling seniors and caregivers about Medicare and related benefits, and she was also a certified New York State Health Insurance Assistance Program counselor. If you would like to read more about Amanda or myself, you can do so on our website.
Thanks, Sophia. Today, I'm going to start by reviewing some important health insurance terms and reviewing how it is that people in the United States access health insurance. I'll then talk about the main options that people have when they lose health insurance at work. And those options include COBRA, Medicaid, the health insurance marketplace, other group health insurance plans, and Medicare. And then we'll conclude today with some tips about how to compare options once someone has identified what options they have. One of the challenges when we talk about health insurance in this country is it is so complicated that a lot of Americans just don't understand how it works or how to go about selecting a health insurance plan. In fact, 96% of the people in this survey couldn't define these four basic terms that are used across all different types of health insurance to talk about what the insurance costs. So if you have wondered about what different terms mean, or you've been confused by things that you've read in connection with health insurance, I want you to know that you're not alone. I am, though, hoping that after today, you're going to be among the 40% of Americans who say they do feel confident about choosing the right plan for themselves. Because the importance of being able to do that is really, it can't be overstated. Making sure you have adequate health insurance coverage and that you know how to use that coverage to your benefit is the best way that we know, not only to make sure you can access care that you need, but also to minimize the cost of a cancer diagnosis. So the first terms I want to review concern networks. The majority of health insurance plans in this country have networks of providers. The insurance company goes out and contracts with providers, with physicians, hospitals, labs, physical therapists, pharmacies, so that those providers are going to give services to plan members for a set contracted amount of money, allowed amount. If you go to a provider who is in your plan's network, you're charged that allowed amount. But if you go to a provider who's not in your plan's network, one of two things will happen. Either your insurance policy is going to cover these services, but they're going to do it at a higher rate. Or if you have a plan that doesn't provide for any out-of-network coverage, it's not going to provide any coverage for the services at all. Regardless of where someone gets their health insurance, regardless of whether it's through an employer or a marketplace plan or a government plan, you have to know the meaning of these basic terms, all of which concern what your insurance is going to cost. First, there's the cost just to have the health insurance to begin with, and that is your premium. It is a fixed dollar amount that you pay each month, and you're going to pay it whether you are seeing doctors all the time or whether you spend a whole year and never see a doctor at all. Then there are costs when you actually use your health insurance. The first of those is your deductible. Again, a fixed dollar amount that you pay out of your own pocket before your insurance kicks in and starts sharing in costs with you. Deductibles are going to vary by plan. They can be super high. They can also be really low or even zero, where a plan starts sharing in costs on day one. Then there is a cost each time you go and get care, each time you see a doctor, or each time you go to the pharmacy to fill a prescription. That can be expressed in one of two ways, either as a fixed dollar amount, in which case it's called a copayment, or as a percentage, in which case it's called a coinsurance or a cost share. So if every time I go to my primary care physician, I pay $20, that's a copayment. If every time I go to my primary care physician, I pay 20% of the cost of the visit, that's a coinsurance. The final term related to cost that I want everyone to understand is out-of-pocket maximum. That is, again, a fixed dollar amount, and it represents the most that someone is going to pay out of their own pocket for their covered medical expenses during the year. Once someone reaches their out-of-pocket maximum, their plan takes over and pays 100% of their covered expenses. So the dollar amount of someone's out-of-pocket maximum can vary plan to plan, and so can how a plan decides what amounts count towards getting to that out-of-pocket maximum. So as an example, if you have a health insurance plan you purchased on your state's marketplace, your out-of-pocket maximum represents the sum of what you have paid towards your deductible and all of your co-payments and all of your co-insurance amounts. Quick example of how this is going to work. So here's Dan. Dan purchases an individual health insurance plan on his state marketplace, and his plan has a $2,000 deductible. It's structured as an 80-20 co-insurance. So his plan pays 80% of costs, he pays 20%, and the plan has an $8,000 out-of-pocket maximum. Dan ends up in the hospital towards the beginning of the year with a whopping $102,000 bill. How much of this does he have to pay? So he's going to have to pay the first $2,000 to satisfy his deductible, which leaves a balance of $100,000. His co-insurance amount is 20% of that, or $20,000. But that's not the end of our analysis. He has an out-of-pocket maximum of $8,000. He has already paid $2,000 towards that in the form of his deductible, which leaves a balance of $6,000. So it's only $6,000 of that remaining $20,000 that Dan is responsible for paying. And then the $6,000 that he pays for co-insurance plus the $2,000 deductible adds up to the $8,000 out-of-pocket maximum. Not saying $8,000 isn't a lot of money. Of course it is, but it's still a lot less than $20,000, let alone $100,000 or $102,000. If you want to hear that example again, or if you know someone who you think could benefit from hearing the example, it is covered in our animated video about health insurance basing. So there are some nuances to out-of-pocket maximums. I mentioned that Dan purchased an individual plan, but of course there are a lot of people whose health insurance comes from family plans. If you have a family plan, each of the covered individuals will have an out-of-pocket maximum, and the family will have an out-of-pocket maximum. I also mentioned that Dan purchased his plan on his state marketplace. By definition, all marketplace plans say that the out-of-pocket maximum includes all amounts paid towards your deductible and all of your co-payments and all of your co-insurance amounts for both medical care and prescription drugs. But non-marketplace plans may not define out-of-pocket maximum in that same way. So if you have an employer plan, it might not look at what you've paid towards your deductible. It might only be looking at what you've paid for co-payments and co-insurance amounts. It might not even look at your co-payment amounts. It might only be adding up what you paid for your co-insurance to get to the out-of-pocket maximum. And it also may not include amounts you've paid for prescription drugs. Some plans have a separate out-of-pocket maximum for medical care and a separate one for for prescription drugs. There can also be a separate out-of-pocket maximum if you have a plan that includes out-of-network coverage. I want to review some terms related to prescription drugs. And the first of those is formulary. Formulary is really just a fancy word for the list of drugs that are covered by your insurance plan. Formularies are broken down into different levels or tiers, depending upon what the drug is and what the associated cost is. The number of tiers can vary by plan, but in general, the lower numbered tiers are where you'll find your less expensive drugs like generics and where you'll find low copayment amounts. And higher numbered tiers are where you're going to find specialty drugs, newly approved drugs, a lot of the drugs used to treat cancer, and a higher amount that's associated with them, like a coinsurance. If you fill a prescription for a drug that is not on your plan's formulary, you are responsible for 100% of the cost of that prescription, and any amounts you pay are not going to count towards your deductible or your out-of-pocket maximum. Generally speaking, if the drug is not on a plan's formulary, then it's not going to be covered. But there are some steps that people can take to try and get their plan to cover a drug that they need if the plan typically doesn't cover it. So first, it's possible to make what is called an exception request. There are two types of these. There's a brand exception, where you or your doctor ask a plan to cover a brand name drug when the plan only includes the generic version of that drug on its formulary. There's also a tiering exception, which is where you ask the plan to let you pay for a higher tier drug at a lower tier's cost. You can make an exception request in a situation where the drug on the plan's formulary or the lower tier drug doesn't work for you. For example, maybe you're allergic to it, or maybe you've tried the drug and you've had an adverse reaction. In addition to making an exception request, you can also appeal a decision from your plan not to cover a drug. But also understand that even when your plan covers a drug that you need on its formulary, the plan can still find ways to restrict access to the drug. So, for example, a plan might require prior authorization. In other words, special permission from the plan before your pharmacist can fill the prescription. A plan can also impose quantity limits on how much of a drug someone can access. And a plan can impose step therapy requirements. Step therapy refers to asking a patient to demonstrate that they have tried a less expensive drug to treat their condition and that the less expensive drug isn't effective before the plan agrees to pay for a more expensive drug. So now that I've covered some of the terms that are important regardless of how someone is getting their health insurance, let's just take a minute and remember where it is that people in the US can look to when they're trying to get health insurance coverage. The first place they can look is purchasing directly from an insurance company. So this includes plans that are purchased through the health insurance marketplace. The marketplace itself is regulated by the government, but when someone purchases a plan on the marketplace, they are buying that plan directly from an insurance company. They're not buying government coverage. The second place Americans look to for health insurance is the government, and that includes Medicare and Medicaid, both of which we will spend time talking about later. This could also include coverage through the Veterans Administration, military coverage, the Indian Health Service, and other state or local plans that might be offered to certain specific groups of people. The third place Americans look to for health insurance coverage is an employer. It could be your own employer, it could be your spouse's employer, or even a parent's employer. This also could include COBRA coverage, and that is where we're going to start today in talking about the options someone has when they lose coverage at work. COBRA is the federal law meaning the law in all 50 states, that allows eligible employees to continue to be covered under the exact same health insurance policy that they had when they were. COBRA applies to private employers with at least 20 employees and to local and state governments of any size. So if someone is an employee of the federal government, they might have similar continuation rights, but they come from a different law. The major benefit to COBRA is that it is the exact same coverage. So someone doesn't have to go and try and find a new plan and make sure their providers are in that plan or that their prescription drugs are covered by that plan. And everything that someone has paid already for the year towards satisfying their deductible or their out-of-pocket maximum continues to apply. The major downside to COBRA is it can be really expensive, because under COBRA, an employee becomes responsible for paying 100% of the premiums for the health insurance. Plus, sometimes they can even be asked to pay an additional 2% administrative fee. So those premiums can start to feel really, really high, especially if your employer was covering a large percentage of the premiums while you were still working. I also want to be clear before I move forward and talk more about COBRA, that when I say COBRA, COBRA itself is not health insurance, and it's not a specific policy. COBRA is just the law that's allowing someone to continue with the same health insurance coverage. The amount of time that you get to keep your health insurance under COBRA depends on something called your qualifying event. In other words, whatever it is that triggered your right to COBRA in the first place. So if what triggered your right to COBRA is that you're leaving your job, or even if you went from being full-time to part-time and your employer doesn't provide benefits for part-time employees, then you generally get to keep COBRA for up to 18 months. Instead, if your qualifying event is, let's say you age out of your parents' policy, or let's say you're covered through your spouse and you divorce your spouse, or you're covered through your spouse and your spouse becomes Medicare eligible, you may be eligible for up to 36 months of COBRA in those circumstances. There are two instances where you may be able to extend COBRA coverage longer than the time periods that I just mentioned. The first of those is what we call a disability extension. If the Social Security Administration deems you to be disabled, and you are disabled at any point during the first 60 days that you have COBRA, you can extend the 18 months of COBRA by an additional 11 months for a total of 29 months. And this is allowed in order to bridge the gap until this disabled person becomes eligible for Medicare. If that happens, though, your premiums can actually go up even higher, all the way to 150% of their total cost. So keep that in mind. The second instance where you may be able to extend COBRA coverage longer than the times I just gave you is if you have a second qualifying event. So for example, let's say you initially became COBRA eligible because your spouse lost their job, but then a few months later, your spouse passes away. That would be a second qualifying event, and you would be able to extend the initial 18 months of COBRA up to 36 months. In general, if you elect COBRA, you can choose to stop the COBRA at any point. So for example, if you elect COBRA and then you go and find a new job with health insurance coverage and you want to take advantage of that coverage, you can drop COBRA. You just have to be careful that if you do that, you do it at a time when you are able to enroll in whatever new insurance you have found. On the other hand, your insurance plan can't just choose to terminate your COBRA unless one of a very few specific things happens. So the plan can terminate coverage if you don't pay your premiums or if you commit fraud. For example, if you were to lie to the insurance company on your application. So definitely don't do that. COBRA can also stop if your employer stops offering health insurance to all of its employees or if your employer goes out of business. And it can be terminated if you become eligible for Medicare. And I'm going to talk more about that when we get to the section about Medicare. An employee has 60 days to elect COBRA. And those 60 days get measured from the later of the date of their qualifying event or the date that their employer provides their election. Someone can potentially wait all the way until the end of that 60-day period to elect COBRA coverage. And if they do, the coverage goes back retroactively to day one, but you also have to then pay your premiums retroactively back to day one. And you get 45 days from when you make your COBRA election to make your first premium payment. One really important thing to understand about COBRA is family members don't have to make the same decisions. So an employee and any of their dependents who are covered under their health insurance, like a spouse and children, can make different choices. For example, let's say the employee in this situation is the person dealing with a cancer diagnosis. And maybe they've already had a lot of healthcare during the year, and so they've already met their out-of-pocket maximum. But they have a spouse and children who are covered by their plan, and all of those family members are pretty healthy. They haven't really gotten any healthcare so far this year. It's possible that it'll make financial sense for the employee to take COBRA, but for the family to go and pick up a marketplace plan, or maybe some of the family members will qualify for CHIP. It's just important to understand people can make different decisions in these situations. During the COVID public health emergency, the Department of Labor gave an extension to people so that instead of having to elect COBRA within that typical 60-day time frame, they gave people until 60 days after the end of the COVID public health emergency to do it. Earlier this year, the government announced that the public health emergency was ending. In fact, it ended last week on Thursday, May 11th. As a result, the Department of Labor has issued some guidance about how they're going to wrap up the end of this COBRA deadline extension. And so what they've done is they've said that access to the extension is going to continue through what they are calling an outbreak period. And that outbreak period is going to end on July 10th, which is 60 days after last Thursday, after the end of the public health emergency. So what does all of this mean? It means that if someone has a COBRA qualifying event and the event happened anytime during the public health emergency, or it happens anytime during this outbreak period, they're going to get 60 days from the end of that period, or 60 days from July 10th to elect COBRA. And this chart gives you some examples of how that might work. So the first row shows you a qualifying event that happened during the COVID public health emergency. The second row is a qualifying event that happened last Friday, one day after the public health emergency ended, but during this outbreak period. And the third row is showing you a qualifying event once we go back to the pre-COVID rules. Now, what happens if you work for an employer that has fewer than 20 employees, a private employer with fewer than 20 employees, I should say? Federal COBRA law in that situation isn't going to help, but you might not be out of luck. So there are state COBRA laws, sometimes called mini COBRA, that could be useful to someone. The details are going to vary state to state, but depending on where you live, you might have access to similar continuation benefits. You have to get details about what size of employer is covered in your area and how long the continuation benefits will last. And we do have a chart of state laws on our website that shows you that information in each state that has a mini COBRA law. So as with most things, there are pros and cons to COBRA. When I talk to individuals, inevitably, the moment I say the word COBRA, if this person is at all familiar with what COBRA is, the first thing they say to me is too expensive. And that is definitely sometimes true, but it isn't always true. Keeping COBRA can sometimes actually cost less overall than switching plans, because while someone's premiums are going to go a lot higher, if this is a person who's already satisfied their deductible and met their out-of-pocket maximum, then they're comparing the cost of COBRA, which will be several months of premiums, to the cost of a whole new plan where you're going to have to pay those months of premiums. Plus, you're going to have to start over on $1 with satisfying a new deductible and a new out-of-pocket maximum. So you have to compare the total cost of staying with COBRA to the total cost of a potential new plan. You also have to compare the quality of coverage that's being offered. So what size network does each plan have? Are the doctors you want to see in each of the plans? What percentage of a plan, what percentage of out-of-pocket costs are covered by each plan? What do the formularies look like? Maybe your COBRA plan would be better, but maybe a new marketplace plan would. These decisions really have to be made on a case-by-case basis, and people should consider all of the options available to them. Because COBRA can be expensive, I want to share information about a program that could be available to help you with the cost of COBRA premiums, and most people are not aware of this program. In some states, definitely not all, but some, there is a program called the Health Insurance Premium Payment Program, or HIP. Not HIPAA, the privacy law, but HIP. In a state with a HIP program, if you're eligible for Medicaid, but you also have access to an employer group health plan through COBRA, the state Medicaid program may pay your health insurance premiums for you rather than have you enroll in Medicaid. The state would do this because it would cost the state less overall to pay the premiums for COBRA than it would to pay for all of someone's health care under Medicaid. And again, you can look at our charts of state laws to see if there is a HIP program where you are. So speaking of Medicaid, that is our next option when someone is using employer-sponsored coverage. Medicaid is government health insurance for people who have low incomes and sometimes low resources or assets. Even though Medicaid is a federal program and it exists in all 50 states, it is funded through a partnership between our federal government and the states. And because of that, states have flexibility in how they design and operate their Medicaid programs. What that means from a practical standpoint is the rules for Medicaid eligibility and the rules around how Medicaid works differ from state to state, and sometimes they differ dramatically. This can create some real challenges. So be careful. As an example, if you were talking to a friend or a relative who lives in another part of the country, or if you're a member of an online support community and you talk to people who say, well, of course you'll get Medicaid in this situation because they've gotten Medicaid. Keep in mind that the rules in their state and the rules in yours may look different. One of the differences right from the get-go is that different states have different names for their Medicaid programs. So while Delaware and Florida and New Mexico have stuck with the traditional name Medicaid, if you're in California, it's Medi-Cal. If you're in Maryland, it's medical assistance. I like Connecticut, Husky Health, and I like Wisconsin, that's Badger Care Plus. But you can see even what we call it can look different. Before 2014, in order to be eligible for Medicaid, someone had to have a low income and low resources, and they had to meet one of these 4 other criteria. They had to be able to open one of these 4 doors in order to access Medicaid. In the cancer community, usually people got their access to Medicaid through the age blind and disabled program. Left, not the best name for a program, but that's the one they were using. The age blind disabled door makes someone jump through a lot of hoops because unless someone is 65 or older or they're blind, in order to get through that door, in addition to your low income and your low resources, you had to go to the Social Security Administration. You have to apply for the Supplemental Security Income Program, and you have to be approved for that program because in most states, this will automatically qualify someone to get Medicaid. The Affordable Care Act created a 5th door for eligibility, and this new door actually eliminated one of the barriers that otherwise existed. The 5th door lets someone be eligible for Medicaid solely based on their income. So if an individual has income that's at or below 138% of the federal poverty level, they are eligible for Medicaid. There's no asset test, no looking at resources, no seeing how much money someone has in the bank. It's just about income. So today, this is what Medicaid looks like. You have the 4 older doors that continue to exist, but now we've added this new door as well. And if someone's eligible to walk through the new door, they can access Medicaid a lot faster than going through the age blind disabled door where they have to go through the entire supplemental security income application process. When the 5th door was created, the intention was for it to exist in all 50 states. However, there was a legal challenge to the Affordable Care Act, and then there was a Supreme Court decision. And as a result, this 5th door became voluntary. So now each state can decide for itself whether or not they're going to have this door. And as a result, this is what our country looks like today in terms of Medicaid expansion. The states on the left side of the slide have chosen to expand access to their program, and they have the 5th door. And the states on the right side of the slide don't. They have not expanded. North Carolina is in red because their governor has signed Medicaid expansion into law. That happened earlier this year, but expansion is contingent on their state passing its budget, which hasn't happened yet. So stay tuned because we hope we're going to be able to move North Carolina to the left side of the slide really soon. In terms of why there are all those footnotes in small print at the bottom of the slide, those represent states that didn't initially expand their Medicaid program, but eventually did. So it shows when that happened for each of the states. States can operate Medicaid either as a fee-for-service program or as a managed care program, or they can operate it as a combination of the two. So in a fee-for-service system, healthcare services are not bundled together. Someone goes to a doctor or they go for a test, and as long as their provider accepts Medicaid, the Medicaid program is going to pay that provider directly. In other states, Medicaid may require someone to select a managed care plan through a private insurance company, and that insurance company then provides Medicaid coverage. And in these instances, the managed care plan may limit the choice of providers to whoever is in their network. Medicaid is not without some costs. So there are circumstances where Medicaid may be able to charge limited monthly premiums or enrollment fees in order to get coverage. You have to check your state's rules to see whether you fall within a group that may have these types of costs. There can also be out-of-pocket expenses associated, in particular with respect to prescription drugs. So Medicaid may charge copayments, which are going to be different if it's a brand name drug versus a generic drug. They may be different for people who are at different income levels. There may even be coinsurance amounts. There are certain groups that are exempt from paying out-of-pocket costs, and there are also some services where Medicaid isn't allowed to impose. So as an example, if you have Medicaid and you need hospice care, there are no out-of-pocket costs. Another example of a time when Medicaid might impose out-of-pocket costs is if someone goes to an emergency room to get services that are really not emergency services. Emergency room services are exempt from out-of-pocket charges, but if you're getting non-emergency services there, Medicaid can impose a copayment. Medicaid applications are accepted year-round. You can apply on your state's marketplace if you think you're eligible based on low income alone. But if you're trying to go through one of the other eligibility doors, like that age blind disabled door, you can apply through your state's Medicaid agency, which is typically going to be your local Department of Social Services. You can find out who your state's Medicaid office is and get their contact information by using Triage Cancer's state resources page. If you are determined to be eligible for Medicaid, your coverage is typically effective as of the date you applied or as of the first day of the month when you applied. Sometimes you can even be eligible for up to 3 months of retroactive coverage prior to your application date if you would have been eligible during that time period. And your Medicaid typically is going to end at the end of a month when you no longer meet the eligibility requirements for the program. So far, we have talked about 2 options for when you lose employer-sponsored coverage. We've talked about COBRA and we've talked about Medicaid. Let's turn to a third option, and that is the health insurance marketplace, or as some people refer to it, the exchange. I think of the marketplace as a virtual shopping mall where the only product someone is shopping for is private health insurance. This is where you can go to find out what private plans are available in your area and to see if you qualify for Medicaid in your state. And there are a bunch of benefits to shopping for your coverage through the marketplace. One of those benefits is that this year, no plan sold on the marketplace can have an out-of-pocket maximum that is higher than $9,100 for an individual or $18,200 for a family. And those numbers are high, but they can actually be even higher if you are purchasing a plan off the marketplace. Plus, they do ensure that there are limits to what you're going to have to pay for your care and that you know what those limits are. Another significant benefit to purchasing on the marketplace is there's some financial help that's available. So depending on your household size and your household income, there are 2 types of financial assistance that can be available to you. The first are premium tax credits, and those lower the monthly cost of having your insurance. And the second is cost sharing subsidies. Those lower your out-of-pocket costs, but only for certain plans once you've already purchased the plans. Another benefit to the marketplace is that all of the plans sold on it are standardized. That makes it really easy to compare one plan to another plan. All the companies that sell the plans on the marketplace have to offer a plan. The lowest level of coverage is a bronze plan. That's a 60-40 cost share. The plan pays 60% of out-of-pocket costs. You pay 40%. And then the highest coverage level is a platinum plan, which is a 90-10 cost share. Your plan pays 90% of costs, you pay 10%. Platinum plans have the lowest out-of-pocket costs. So as a result, they tend to have the highest monthly premiums. And then the bronze plans that have the highest out-of-pocket costs tend to have the lowest monthly premiums. There is also catastrophic coverage that is available on the marketplace, but it is only available to young adults who are under age 30. I will caution you, catastrophic coverage is not full scope health insurance. So I wouldn't necessarily recommend it to someone because it's not going to cover everything that someone necessarily needs it to cover, but it is there for younger adults. So who's eligible for financial assistance on the market? That depends on whether someone is in a state that has expanded its Medicaid program or not. So this slide shows you what things look like based on income level if you are in a state that has expanded Medicaid. If you have a household income up to 138% of the federal poverty level, you have access to Medicaid. If you are between 138 and 250% of the federal, you have access to both premium tax credits and cost-sharing subsidies, but the cost-sharing subsidies are only if you select a silver level plan. And then if you're between 250 and 400% of the federal poverty level, you get access only to the premium tax credits. As a reminder, if your household income is over 400% of the federal poverty level, you can still buy a marketplace plan. You're just not qualifying for the financial assistance. But if you are in a state that didn't expand its Medicaid program, things are going to look a little bit different. So first of all, in those states, if you are under 138% of the federal poverty level, you're not eligible for Medicaid. Also, because when the Affordable Care Act, the law that created the marketplace, was passed, they didn't anticipate that. They thought everybody at that level would have access to Medicaid. These people also don't have access to the premium tax credits. They do get access to the cost-sharing subsidies, but that's not especially helpful because it doesn't help lower the cost of buying the insurance. It only lowers your cost once you have it. I really want to emphasize how valuable marketplace financial assistance is. A lot of times people assume that the marketplace plans are going to be expensive. The plans can be even lower priced than what you might be expecting. So in 2021, the American Rescue Plan Act was passed, and that added even more financial assistance for the marketplace, so that now if you are within 138 to 150% of the federal poverty level, if you are in the yellow column, you can find a marketplace plan for $10 or less per month. The American Rescue Plan Act also added financial assistance at the higher end of the income scale. So if you make more than 400% of the federal poverty level and your actual cost of insurance is going to be more than 8.5% of your household income, you can get financial assistance that will drop the cost of the health insurance down to 8.5%. The American Rescue Plan Act's assistance was set to expire at the end of last year, but last summer, with the passage of the Inflation Reduction Act, this financial assistance has been extended all the way through 2025. There are a number of ways to enroll in a plan on the marketplace. There is a website called healthcare.gov that I think is the best starting place for most people. This is the federal marketplace website. Some states actually run their own marketplaces and they have their own marketplace website. But even if you live in one of those states, you start out at healthcare.gov and you put in what state you're in, you will get an immediate link so that you can transfer over to the appropriate state website. So I feel like if you're going to memorize one website or remember anything, remember healthcare.gov. A lot of people, of course, still don't have access to the internet, or they're leery of making a purchase like this through the internet. So know also that there is a toll-free phone number you can call to enroll, and you can still enroll on paper that you mail in or fax in. The Affordable Care Act also included funding for individuals who can provide in-person help with enrolling on the marketplace and also with comparing marketplace plans. The in-person help comes from people who are called marketplace assisters. They are people who are trained and they are certified by the marketplace to provide consumers with accurate and objective assistance when they're navigating the choosing of a plan. I know a lot of people use insurance agents or brokers when they're shopping for health insurance. Unfortunately, we have seen some studies that suggest that agents and brokers aren't always on their best behavior. We've seen studies that show agents who engage in misleading marketing or brokers who have not been honest. I'm obviously not saying that all brokers and agents are doing this sort of thing, but even a great broker or agent who is helping you and who's knowledgeable, they're going to be paid, at least in part, based on what plan they get you to choose. So if you want to work with someone who has absolutely no financial incentive to lead you one way or another, that person is going to be a marketplace assister. If you want to find a marketplace assister, it's actually pretty easy to do that. There's a button on the marketplace website to find local help. You go there, you enter your zip code, and then you get to this page. And if you click on type of local help, you get this drop-down menu. You can click assister, and that way you only see assisters. You don't look at any agents or brokers. And states that have their own marketplace websites all have similar functions somewhere for you to search for someone in those states. So once you decide on a plan, whether it's marketplace or not, you have to know when you're allowed to enroll in the plan. And this slide shows you when open enrollment typically happens for the major types of health insurance that I'm talking about today. So if you are looking at an employer plan, open enrollment varies. It is often in the fall, but to know for sure, you need to talk to your human resources department or your benefits department. As I mentioned, with Medicaid, applications are accepted year-round. With Medicare, which I'm going to get to in a little bit, there is an annual fall open enrollment period. It goes each year from October 15th through December 7th. And whatever plan you select during that time is effective for the following calendar year. It becomes effective the following January 1st. And the marketplace open enrollment period works similarly. It goes from November 1st through January 15th. But if you want coverage that's going to start January 1st, you need to enroll by December 15th. And again, you're selecting a plan for that next calendar year. If you wait until after December 15th to enroll, you can still have coverage for that following calendar year, but you may be waiting a little bit into January or until February before the coverage becomes effective. Some states, in particular states with their own marketplaces, may have longer or slightly different open enrollment periods. So it's really important to check with your state and make sure you understand the rules in that state. But of course, you're not always losing your employer-sponsored coverage in the fall to coincide with open enrollment. So the Affordable Care Act recognized that changes don't just happen during that fall period, and they created special enrollment periods for situations where people lose coverage or they have life-changing events. So if you lose your employer-sponsored coverage, or you're losing if you've lost employer-sponsored coverage in the last 60 days, or you think you're losing that coverage in the next 60 days, you get a special enrollment period to go and purchase a marketplace plan. You also can get a special enrollment period if you move. So it could be moving to a new zip code or moving to the United States from abroad, or it could be a student moving home from school, or even a seasonal worker who's moving to their new work location. You also can get a special enrollment period for life-changing events like getting married or having a baby or adding a child to your family, divorce, a legal separation, or death of someone on a plan. Marketplace coverage generally starts according to set rules. If you enroll by the 15th of the month, coverage is effective the first day of the following month. So enroll May 4th, coverage effective June 1st. But if you wait and you enroll between the 16th of the month and the last day, your coverage isn't effective until the first day of the second following month. So in my example, enroll May 18th, you're not looking at coverage until July 1st. Financial assistance for marketplace coverage is based on the two factors I mentioned earlier, household size and household income. The marketplace website will give details for who gets included and who doesn't get included when you're trying to figure out who is a member of your household. And it will also walk you through how to calculate your modified adjusted gross income, which is the measure of income that they are looking at for when evaluating whether you can get the financial help. It is a specific formula. When you apply for financial assistance, you are actually projecting what you think your income is going to be for the coming year. And then once the year is over, you have to reconcile what you projected against what you actually earned. If you ended up earning more than what you thought you would, you might have to repay some of your financial assistance. But if you ended up earning less than you thought you would, you could end up with a tax credit. You are responsible for reporting any changes in your income, in your household size, or in eligibility for minimum essential coverage to the marketplace within 30 days of those changes happening. And you can do it either online or by calling. You can't do it by mail. And if you're in one of these states that has its own marketplace, you have to find out from your state what the procedure is to report changes. So we've talked about COBRA and Medicaid and the marketplace, all as options for when you lose employer-sponsored coverage. Our fourth option is enrolling in a different group health insurance plan. So maybe you found a new job that offers benefits, or maybe you can access a new group health plan through your spouse or through a parent if you're under 26. If you are considering enrolling in a new group health plan, make sure to ask when coverage under that plan is going to be affected so that you can ensure that there's no period of time when you become uninsured. Also, make sure that there's a special enrollment period if this isn't happening during a time of open enrollment. There are other types of commercial health insurance plans too. So maybe someone is a student. Thanks to the Affordable Care Act, student health insurance plans now provide full scope health insurance protections. So that might be a good option. But there are other types of commercial insurance that we want you to be cautious about. In particular, short-term plans and association health plans, because those types of commercial insurance are not required to comply with the Affordable Care Act. And we often, unfortunately, find that people have problems with those types of plans. So the final option that I want to talk about today is Medicare. Medicare is public health insurance for US citizens and certain legal residents who are age 65 and older, or who've been receiving Social Security disability insurance benefits for at least 2 years, or who have end-stage renal disease or ALS. Medicare is complicated. I am going to try and provide some basic information about it, but certainly I won't have the time to talk about everything involved with it. Medicare is divided up into parts. I want to make sure we understand what each part covers and what it costs. Medicare Part A is hospital insurance. It's what I'm going to refer to as hospital insurance because it covers things like inpatient stays in a hospital or in a skilled nursing facility, very limited stays at nursing homes. And this is also the part of Medicare that covers hospice care. Generally speaking, if you have worked and paid into the Social Security system, Part A is premium free. There is no monthly cost just to have it. If you have not paid into the Social Security system for long enough to get premium free Part A, you can still get Part A. You're just going to have to pay a premium for it. And the amount's going to depend on what work history you have. Part A also has a deductible. Now, most of the time when we talk about health insurance deductibles, they're annual deductibles. They are per calendar year or per year in general. Medicare Part A's deductible is per benefit period. And this year it's $1,600 per benefit period. And a benefit period is measured starting the first day someone is admitted to a hospital or skilled nursing facility, and it ends when the person hasn't received any inpatient care for 60 days in a row. So depending on someone's health situation, it's possible they could have multiple benefit periods during the course of a year and then be responsible for paying a deductible more than once during the year. There's also a cost share in Part A. It's based on the number of days that someone has been in the hospital or other facility. If you are not eligible to get Part A premium free and you didn't buy Part A when you were first, or you didn't enroll in it when you were first eligible, you may be subject to a late enrollment penalty. Your monthly premium would go up by 10% when you do decide to enroll, and you are stuck paying that higher amount for twice the number of years that you could have had Part A but didn't sign up. Medicare Part B is what I'm going to refer to today as medical insurance. It is coverage for things like going to the doctor, going to the lab for a blood draw, having a physical therapy appointment, basically all of your outpatient care, preventative care, some home health care, and durable medical equipment that you may need. Medicare Part B is never free. Even if you have that work history that you needed for premium-free Part A, there is a premium for Medicare Part B. This year, for most people, they pay $164.90 a month. I say most people because if Medicare considers you to be high income, you will have to pay more. Part B has an annual deductible. This year it's $226, and it's structured as a cost share. Medicare pays 80% of costs, you pay 20% out of pocket. Unlike marketplace plans or employer-sponsored plans, there's no out-of-pocket maximum for Medicare Part B or Medicare Part A for that matter. So if you have a serious health condition, your costs can really add up. I am going to talk about some strategies to control that in just a few minutes. If you don't sign up for Part B when you're first eligible, you may have to pay a late enrollment penalty, and that stays with you as long as you have Part B with limited exceptions. Your monthly premium would go up 10% for each full 12-month period that you could have had Part B, but you didn't sign up. Medicare Parts A and B together are what we refer to as original Medicare. And that's because that's all that existed of Medicare when President Johnson signed it into law back in 1965. Original Medicare is a fee-for-service system. Again, that refers to a plan where services are not bundled together. So each time someone goes to the doctor, for example, Medicare would pay that doctor directly for the service. Fee-for-service plans allow for the greatest choice of providers. So if you have original Medicare, you can go see any provider. You can go to any doctor, go be treated at any hospital throughout the United States, so long as that provider accepts Medicare. For the moment, I'm skipping over Medicare Part C. I'll come back to it, but I'm going to jump to Medicare Part D. D is for drugs. Part D is the prescription drug benefit. It was added to Medicare much later. It only became effective in 2006, and it's comprised entirely of plans from private insurance companies. There's no government drug plan or government Part D plan, original Part D, none of that. It's all through a private insurance company. Each of these companies has its own cost structure and its own formulary, its own list of drugs that it covers. In terms of premiums, they're going to vary. The average this year is around $33 a month, but in some areas, there might be a plan as low as $6 a month, in others as high as $111 a month. And again, if Medicare considers you to be higher income, you're going to have an amount tacked on to that. Plans do not have to have deductibles. In fact, there are plenty of Part D plans with zero deductibles, but they can have one. And if they have one, it can't be higher than $505 this year. And then co-payments and co-insurance amounts are going to vary based on the plan and based on the drug you're talking about and what tier it's on in that plan. As with Parts A and B, or premium Part A and B, if you don't enroll in a Part D plan when you're first eligible and you don't have what's called creditable coverage, you may have to pay a late enrollment penalty when you do enroll, and it will stay with you for as long as you have Medicare. Creditable coverage refers to coverage at least as good as what Medicare provides. Medicare has a whole bunch of rules around what coverage is or isn't creditable. If you have another type of drug coverage, your plan should be able to tell you whether or not the coverage is creditable. And if you ask for that in writing, they should be able to provide that information to you because you may need to give it to Medicare later on. And again, if you don't enroll when you're first eligible and you don't have creditable coverage, you may have a late enrollment penalty, which is calculated as 1% of an amount that Medicare determines. They call it their national base beneficiary premium. And then they multiply 1% of that amount by the number of months that you were eligible for Part D, but you didn't sign up. So Part D has changed a lot since it came about. And I want to show you how it works today and then share some changes that are coming soon. So today, if you have a Part D plan, the first thing that someone is going to pay is their deductible. Again, a maximum of $505. After that, they enter what is called initial coverage. And during this phase, Medicare pays 75% of drug costs and the individual is responsible for 25%. And that could continue through the whole year. But if someone's total out-of-pocket drug costs hit $7,400, and again, that's a $2023 amount, but that's the amount for this year. If they hit it, they end up entering what is called catastrophic coverage. And during this phase, Medicare steps up, pays 95% of drug costs. And the individual is responsible for the balance, which is the greater of 5% for these specific dollar figures for generic and brand name drugs. So you can see there is now coverage throughout the whole year. There's no more, they used to call it the donut hole or coverage gap. That's gone, but that's not to say that this coverage system is perfect. But things are changing. So last year, we got this new law called the Inflation Reduction Act that is bringing some significant changes to Medicare Part D. Starting next year in 2024, that 5% catastrophic coverage payment that I just mentioned is going away. And then starting in 2025, there's going to be a $2,000 cap on drug costs, a $2,000 out-of-pocket maximum. It's going to apply both to a standalone Part D plan and to Medicare Advantage plans that include drugs. I'm going to talk about those in a minute. If your plan has a deductible, whatever you pay towards the deductible is going to count towards getting to that $2,000. The cap is expected to increase over time. The other big change happening in 2025 is plans are going to have what they are calling a smoothing mechanism. We're still waiting for details about how this is going to work, but essentially it's going to mean that if you owe a big amount of money for drugs, you're not going to have to pay it in a lump sum. You'll be able to spread it out throughout the year. So far, I talked about Medicare Part A, hospital insurance, Part B, medical insurance, and Part D, drug coverage. I skipped over Part C. What is that? That's the Medicare Advantage program. It's an alternative to original Medicare, where you get your Medicare benefits through a managed care plan sold by a private insurance company. That plan bundles all the services together that someone would otherwise get under Parts A and B. And the vast majority include drug coverage as well. And these plans operate similarly to employer-sponsored plans or marketplace plans that people may be used to. The plans can be structured in a few different ways. The most popular are HMOs and PPOs. And the plans will all have their own specific networks of providers. And they can also include some benefits and services that are not covered under original Medicare, things like routine dental and vision care. In terms of their cost, premiums can vary. But whether or not the Advantage plan has a premium, you still have to pay your usual Part B premium. So if you hear about a Medicare Advantage premium, that is on top of the Part B premium. And if you hear about a Medicare Advantage plan with a zero premium, it doesn't mean that you don't have that Part B premium. Deductibles, cost shares, all of that varies by plan. One really significant thing to understand with Advantage plans is that they have to have out-of-pocket maximums. And this year, the highest out-of-pocket maximum one of these plans can have for in-network services is $8,300. Out-of-pocket maximums in Advantage plans are for medical care. They are for services that would otherwise be covered under Medicare Parts A and B. They do not look at costs for prescription drugs. So people sometimes say, like, which is better, original Medicare or Medicare Advantage? Medicare Advantage plans have their pros and cons, like everything else. To me, some of the best pros are that they have a stated out-of-pocket maximum and they cover some of the things original Medicare doesn't. And the most significant con in my book is that coverage can be limited to a network, and the networks tend to be regional in nature, and they may not include providers you want to see right now. They may also exclude a provider who you don't even realize yet that you're going to want to see later in the year. As I mentioned earlier, unlike the marketplace plans, unlike the employer-sponsored plans, and unlike Medicare Advantage plans, original Medicare has no out-of-pocket maximum. So a way to control out-of-pocket costs with original Medicare is by purchasing what is called a Medigap plan or a Medicare supplemental plan. These are private insurance plans that someone purchases directly from an insurance company. These plans pay for out-of-pocket costs that come up through Medicare Parts A and B. There are some Medigap rules that are going to apply regardless of where someone lives in the country, but Medigaps get regulated by each state, by their state insurance department or financial regulators. And so that basically means that every state can also have its own Medigap rules. So it's super important if you're looking at Medigaps to know what the rules are in the state where you live. Most states standardize Medigap policies using the letters A through N that you see on the screen, though I know some of them are missing. I'm going to just start out by saying every time I say this, I'm just blown over by how ridiculously confusing it is. I just finished talking about Medicare Parts A, B, C, and D, and now you see it A, B, C, and D on this slide, and they have nothing to do with what I just talked about. On this slide, and in the Medigap context, A, B, C, and D are talking about specific types of Medigap plans, as are the rest of the letters you see on this slide. In each state, multiple insurance companies can sell each of these different lettered Medigap plans. If you are looking at a specific letter, regardless of the insurance company that is offering the plan, if it has that letter, it has to provide the same basic medical benefits that are outlined in this chart at the rates that are shown in the chart. So for example, if I am in New York and I am shopping for a Medigap Plan G, and I see one insurance company offering the Plan G for $100 a month, and another insurance company is offering a Plan G for $300 a month, both of those Plan Gs have to cover the same basic medical benefits that are listed in the chart at the same rates listed in the chart, even though one company's plan costs triple what the other company's costs. So a strategy for purchasing a plan is choose the letter category you want, and then look at pricing from all of the different companies that sell that letter plan in your area. But how is paying another monthly premium for another insurance policy going to save you any money? Each of the plans is going to pay the deductibles and the coinsurance amounts and the other out-of-pocket costs that are outlined in the chart at the rates shown, so that you don't have to pay them out of your own pocket. So if you're going for a doctor's visit and you have original Medicare and a Medigap, after Medicare pays 80% of the cost of your visit, instead of looking to you to pay 20% out of your own pocket, your Medigap is going to pay that 20%, assuming, of course, that you have one that covers that at 100%. I'll just note plans C and F are off to the side. That's because those plans are no longer issued to people who first became eligible for Medicare after January 1st, 2020. If you were first eligible for Medicare before that date, you can still have these plans. Sometimes people ask us, what's the best Medigap? I'm never going to say what's best for someone else. What I can say is that the most comprehensive Medigap that's available to someone who is newly eligible is Plan G. So there are rules around when someone can enroll in a Medigap or make changes to their Medigap. The best time to do that is when you have what are called guaranteed issue rights. That means that when you purchase a plan, if you have guaranteed issue rights, it means when you're purchasing a plan, the plan can't engage in medical underwriting. It can't look at your health history to make a decision about whether it's going to sell you the policy or how much it wants to charge you. There are a bunch of different circumstances when someone has guaranteed issue rights. You can see a full list on Medicare's website, but you also need to check with your state because different states may have additional times. One time when everyone has guaranteed issue rights is the first 6 months someone is both age 65 and has Medicare Part B. If you're under 65, you're eligible for Medicare because you've been getting Social Security disability insurance. It is up to each state to make rules about selling you a Medigap. And there are states that are shown on the slide where there is absolutely no requirement that insurance companies have to sell you a Medigap. If you're in one of those states, it doesn't necessarily mean you can't get one. There's just no requirement that the company sell you one. So you could end up being denied or charged more money based on health status. Every year during Medicare open enrollment, people have the opportunity to switch Medigap plans without going through medical underwriting, as long as they're staying in the same letter category. So if I want to switch from a Plan G that I buy from Aetna to a Plan G from Humana, no medical underwriting. I can also go down a letter level, like give up my Plan G for a Plan B without going through medical underwriting. But during open enrollment, if you've never had a Medigap, or if you're trying to go up a level, like from B to G, you could go through medical underwriting. So unless you have a guaranteed issue right, you could end up being charged more or denied, or a plan could impose a pre-existing condition waiting period for up to 6 months. Although you can sometimes offset that waiting period if you've had creditable coverage. Again, I just want to emphasize Medigap rules really vary state to state. So if you have questions about your right to purchase a Medigap or switch Medigaps, you can start off by checking our charts of state laws. In summary, when it comes to Medicare, think of it as a 2-lane highway. You can drive in one of the 2 lanes. Lane 1 is original Medicare, hospital coverage through Part A, medical insurance through Part B. If you want drug coverage, you pick up a Part D plan. And if you want to limit Part A and B out-of-pocket costs, you purchase a Medigap. The other lane, the other option, one Medicare Advantage plan, one private managed care plan through which you are getting your hospital coverage, your medical insurance coverage. You're probably getting your drug coverage as well. If you aren't, you probably have the ability to get a separate Part D plan there. What you can't do in lane 2 is buy a Medigap. The reason for that, because Medicare Advantage plans by law have out-of-pocket maximums. So as I mentioned, when I was talking about the marketplace, Medicare has different times during the year when someone can enroll or they can make changes to how they get their benefits. And I mentioned the annual fall open enrollment period, but now I want to focus on Medicare's special enrollment periods for when someone is losing employer-sponsored insurance. So Medicare has a specific special enrollment period to enroll in Part B and to enroll in Part A if you have to pay a premium for Part A when you lose employer-sponsored coverage. If someone is currently working and they have employer-sponsored group health insurance, or their spouse is working and has employer-sponsored group health coverage, that person can apply for Part B or premium Part A at any time that they're still covered by that group health insurance. And they can do it for 8 months after their coverage ends or after their employment ends or the spouse's employment ends, whichever is earlier. To be clear, you only have this special enrollment period if you or your spouse is working and has active employer-sponsored coverage. If someone has COBRA or they have retiree coverage, those don't trigger this Part B and premium Part A special enrollment period. It's just active coverage through work. In addition, Medicare has a special enrollment period to enroll in a Part C plan or a Part D plan if someone is losing employer-sponsored health coverage, employer-sponsored drug coverage, or union coverage. For these parts of Medicare, the coverage that you're losing to trigger the special enrollment period actually can be through COBRA or even through a retiree plan. And if you make use of this special enrollment period, you have 2 full months after the month that your coverage ends to enroll. Medicare has special rules for how it interacts with COBRA. If you have COBRA first and then you become eligible for Medicare. So for example, you lose your job, you go on COBRA, and then 3 months later you turn 65, COBRA usually ends. It ends for you. Your dependents might still be eligible to keep it. You also might be able to keep your prescription drug coverage if you want to do that, or coverage for benefits Medicare doesn't cover, like if you have dental benefits. But COBRA is not creditable coverage for purposes of delaying enrollment in Part B, so you have to sign up. On the other hand, if you already have Medicare and then you become eligible for COBRA, you can take COBRA and you can have both types of insurance. Medicare is going to be primary, COBRA is going to be secondary. You're going to be responsible for paying premiums for both of them. So the timing matters a lot. As much as I've tried to squeeze into all of this about Medicare, there's a lot more to learn, and we do have a whole topics page on our website devoted to this subject and links to a lot of resources. Also, our September monthly webinar is going to focus entirely on Medicare to help people prepare for open enrollment. So we've now covered all of our different options after losing employer-sponsored health coverage. We talked about COBRA, Medicaid, the marketplace, other private plans, and Medicare. If we have more than one option, though, how do we go about comparing them? How do we even get the information about the costs and the coverage of the different plans? If you're looking at COBRA, your employer is providing that information. It's your same plan. Medicaid, you have to look at how the program operates in your state. Another group health plan, you have to get those details from the new employer. If you're looking on the marketplace, though, you can go to healthcare.gov and you can browse all the available plans. It'll show you everything available in your area once you enter your zip code. And then there are all of these different filters if you are specifically looking for a certain metal level or only looking at HMOs versus PPOs. And you can get a lot of detail about all of these plans directly from the website. Once you narrow down your plan options, you need to know how you're going to compare them. This exercise is going to walk you through comparing a few different marketplace plan options, but it is equally valuable and usable if you're comparing employer-sponsored options or an employer-sponsored option to a marketplace plan. Here we have 3 different plans available to somebody: a bronze plan, a silver, and a platinum. Each plan has its own monthly premium, its own deductible, its own out-of-pocket maximum. Assuming someone is going to hit their out-of-pocket maximum during the year, because when we're talking about the cost of cancer, the likelihood is pretty high that can happen. Can you tell just by looking at these series of dollar figures how much each of these plans is actually going to cost by the end of the year and which option is going to be the least expensive? And the answer is you can't. You can't tell just by looking. You have to do some math because your goal is to select the plan with the lowest total cost for the year. So to get total cost, we need to multiply each plan's monthly premium times 12, and then add to that the plan's out-of-pocket maximum. And when we do that, what we see happen is that our bronze plan that started out with what looked like a very reasonable low $200 a month premium ends up totally with a total cost of $10,400, which is $3,600 more than the platinum plan, whose monthly premium was twice the price. It is super important not just to focus on premiums. They are only one component of cost, particularly for somebody who expects to have a lot of healthcare expenses and potentially hit their out-of-pocket maximum. Of course, comparing costs is only step 1 of this process. It's also really important to compare networks of providers and plans. Make sure that any providers you want to see or facilities where you want to be treated are in network for a plan. If they're not in network, is a plan you're considering a plan that has out-of-network coverage and at what price? Also really important to compare prescription drug coverage. Are the drugs you take covered at a price you can afford? And are there any restrictions placed on those drugs? The Marketplace website will let you see what providers are members of which plan networks, as well as whether different prescription drugs are covered. I always encourage people to double check any of this information directly with their providers and be really specific about it. Don't just say, do you take Blue Cross? Blue Cross is a company that has probably thousands of different insurance products. You have to give the very specific plan name. And also make sure to let your providers know if you are switching insurance plans, tell them about it proactively to smooth out that transition. We have a lot of resources to help you with comparing plans, including an animated video on this topic, as well as a plan comparison worksheet. And for those who are looking for resources to help them with comparing Medicare plans, Medicare.gov, the Medicare website, has a plan finder tool that's very similar to what I just showed you for the marketplace. You can search by zip code and you can see all of the Part D prescription drug plans and all of the Medicare Advantage plans available in your area, as well as a lot of detail about costs and formularies. And we have a Medicare options comparison worksheet that's similar to the first worksheet I showed you, but that takes into account some specific nuances of Medicare. So to tie all of this together, what everything I've discussed today comes down to is that if you are losing employer-sponsored health insurance, you have more options now than you've ever had before. And the options are represented, again, I like the highway analogy. This time it's got 4 lanes. Option 1 is COBRA, maybe state COBRA, keeping the same health insurance plan you already had. Option 2 is using a marketplace special enrollment period. Option 3 is choosing another group health plan, maybe through a spouse or a parent. But if you're doing so, make sure you've got a special enrollment period to enroll. And then lane 4, based on your circumstances, is maybe you're now eligible for Medicaid or Medicare. The trick with all of this is someone has to look at all of their options and pick a lane, because they don't get to change lanes until the next open enrollment period. What we sometimes see happen with people is someone is leaving their job for cancer treatment. They get handed their COBRA paperwork on the way out the door, and they just reflexively take COBRA because they've got a lot of stuff going on. They know they need their health insurance. They don't want to stop and think about whether there are other options. But then a few months in, they start to realize, gee, this is really expensive. And I found out my doctor takes marketplace coverage. So now I want to change. Can I do that? The answer, unfortunately, is no, you can't, because you've already chosen to drive in that first lane. There is one exception to this rule. Bear with me, because I know that this is like a lot of detail. But let's say someone's in a situation where they've chosen the marketplace, but it's the second half of the month. And we know that that means that coverage isn't going to be effective until the first day of the second following month. So someone is now looking at maybe like a month plus 10 days, 40 days until coverage starts. Most people, if you're in the middle of cancer treatment, you can't go 40 days with no health insurance. They have a special option. They can choose their marketplace plan. They can send in the premium for it, and then they can go back and elect COBRA, but only until the marketplace plan kicks in. But you have to do it in that order. You have to go to lane 2 first, do all the things needed to get the marketplace plan, and then go back to lane 1 to bridge that gap. One other example, just to illustrate everything we've talked about. Here are the Gellers. Ross and Rachel are married. In July, Rachel, who's 25, takes time off from work to deal with her cancer treatment and recovery. She had insurance through her employer. When she told the employer she was leaving, she got her COBRA paperwork. COBRA is going to cost $800 a month. Her husband's insured through his employer. That costs $300 a month. Based on what he earns, that's around 8% of his income. If he adds Rachel to his plan, the premium is going to go up to $500 a month, a much higher percentage of his income. What are the options here? First, does Rachel have the chance to elect COBRA? Sure, she does. Her office gave her the paperwork. She's eligible. Does she have to take COBRA? No. No one's forced to take COBRA if they don't want it. Why might she want COBRA, even though it's expensive? Well, she might like the provider network. She might have already met her deductible. It's July. Maybe she's already had a lot of healthcare expenses this year. Maybe she's met her out-of-pocket maximum, or she's close. Maybe she likes the idea of not having a project, of comparing these other options when she's got a surgery planned, just a few weeks in front of her. She wants to just seamlessly transition from active employment to COBRA. Why might she not want COBRA? Maybe she doesn't like her current coverage. Maybe it is too expensive. Maybe even though it's mid or late July, she actually hasn't had any expenses yet, so she's nowhere close to meeting her out-of-pocket maximum. What about other options? Can she join Ross's plan? Probably. We would just need to confirm that Ross's plan has a special enrollment period for her to join mid-year. We'd also want to confirm when that new coverage under Ross's plan would be effective. What about the marketplace? Could she buy a plan there? Sure. She's got a special enrollment period. She has 60 days from losing the employer-sponsored coverage, or even if she was planning ahead, if she anticipates losing coverage in the next 60 days. If she buys in the marketplace, when is her coverage likely to start? Probably not until September 1st. She's already in late July, so even if she jumps on it right away, her coverage is not going to be effective until the first day of the second following month, which is problematic given that she has surgery scheduled for August. What's the solution for this? It's what I described on the last slide, that last example. She enrolls in the marketplace, and she goes back to COBRA and elects it just to fill in that gap of time. She might even be eligible for financial assistance with her marketplace costs. She can put her information onto her website and see. What if she takes COBRA and then a few months later, she decides too much money? Can she drop it and buy a plan on the marketplace? Only if she finds herself meeting criteria for a different marketplace special enrollment period, or if by the time she wants to do that, it's a few months later and she's in the middle of open enrollment. One other possibility for Rachel, but we don't have all the information in this fact pattern. She's only 25. She could potentially go on one of her parents' plans because she is young. And just to close out the other options I talked about earlier, based on the limited facts we have, it doesn't appear she would be eligible for Medicaid or Medicare. In closing, I just want to remind people, finding out your health insurance options and selecting a plan is just step one in what you have to do in order to access care and lower costs. You also have to know how to use your health insurance. Triage Cancer has lots of resources to help with this, lots of quick guides on topics like understanding basics and pre-authorizations and appeals, and everything can be accessed quickly if you go to our Cancer and Health Insurance Topics page. And finally, if you are losing employer-sponsored health insurance and you or your loved one is leaving a job, health insurance probably isn't the only thing to think about. You also want to think about whether there are other benefits you're losing, things you might be able to convert to individual policies like life insurance. You want to make sure you understand any steps you need to take with respect to tax deferred accounts, retirement accounts. If you can't work for a longer period of time because of your disability, maybe you want to look into accessing private disability insurance, private long-term disability through your job if it's offered. And if it is, what do you have to do to apply? And also think about whether you might be eligible for or want to apply for unemployment benefits. We actually have a quick guide to leaving work that describes all of these considerations so that they are top of mind for you. So I want to thank everybody for attending today. I know that my colleagues have been busy answering questions that have been posed in the Q&A box. Are there any remaining questions? Otherwise, I will throw this back to Sophia for closing it out.
I believe we are ready to close it out. Thank you, Amanda. And thank you so much for such a wonderful, detailed presentation. I would also like to remind everyone that a recording of this webinar, as well as a resource document with clickable links, will be available on our website by the end of the week. I just dropped the link in the chat.